Morning, everyone. My name is Emil Tan. I'm the head and senior consultant of the Department of Colorectal Surgery at SGH, that's Singapore General Hospital. And it's a warm welcome to all of you to the annual Colorectal Cancer Awareness Month public webinar. As you can tell, we do this every year. It used to be with coffee, biscuits, and a Milo truck out front at SGH, but since COVID, it's gone online. Colorectal cancer is the #1 killer in Singapore, and it continues to present at a later stage in Singapore as compared to other developed countries like Korea. So awareness and early screening is really important. What's really important as well is that over 90% of colorectal cancer is treatable when detected early. Detection is simple and screening tests are readily and easily available all over Singapore. And early screening leads to prevention, and early detection often leads to cure. Through today's webinar, we hope to create more awareness of colorectal cancer. With me today are 3 specialists in colorectal surgery. Your panelists, who I'm going to introduce now, Dr. Lionel Chen, Dr. Lin Wenjie, and Dr. Yvonne Ng. So without further ado, let me get Dr. Lionel Chen to speak to you first on his topic, any early sign, wait or take control. Dr. Lionel, please carry on.
Thanks, Prof. Emil. Thank you, everyone, for allowing me the pleasure to speak to you all. I'm Lionel, one of the associate consultants from the Department of Colorectal Surgery, Singapore General Hospital, and NCCS. So today I'll be presenting on any early sign, wait, or take control. So what is colorectal cancer? Colorectal cancer is the cancer of the large intestine or the rectum, which is the passageway that connects between the colon and the anus. In most people, it usually takes several years to develop, usually about 10 years. And it starts as a small polyp, which is an abnormal growth of tissue within the inner lining of the colon or rectum. And over time, it gets bigger and bigger, and the cells within it change, and it starts to invade surrounding tissue as well as the walls of the colon or the rectum. And that is when it becomes a cancer. So colorectal cancer, as mentioned earlier, is the 3rd most common cancer worldwide, but in Singapore, it's the most common cancer among men and the 2nd most common cancer among women. So how do they usually present as, and what are the symptoms of colorectal cancer? Well, it can be a change in bowel habits, whereby you notice that you've been passing motion quite normally, but recently you notice over the past 2 or more than 2 weeks, you have a change in your stool pattern, like it's more constipated, or you have frequent watery diarrhea with feelings of incomplete defecation. And this is sometimes uncomfortable. You still feel very full after you have completed your business. You have blood in your stool, or you have unintentional or unexplained weight loss, whereby you're not even dieting or exercising, but you're losing like 5 kg over 6 months. Or you have persistent abdominal cramps, pain, discomfort, or bloatedness. So all this, which are very non-specific sometimes, are symptoms of colorectal cancer. But unfortunately, in the early stages of it, or even when it is a polyp, there are no early signs of colorectal cancer. In fact, the above symptoms and signs that I mentioned earlier usually only develop in the later stages of cancer, because that is when the growth has grown so big that it causes a blockage in the intestine and causes such symptoms like rectal bleeding, as well as change in your stool pattern, bloatedness, and abdominal discomfort. Therefore, don't wait for the signs. Take control. And how can we take control? Well, you can first start by living healthily. These are modifiable risk factors. Cancer is associated when you are obese, you have sedentary lifestyle, or you eat more processed food, red meat, you drink more alcohol, or you smoke. Therefore, if you maintain a healthy BMI, you exercise regularly, and you eat healthily, and you cut down on smoking or drinking, this helps to reduce your risk of cancer. But the most sure way of preventing colorectal cancer is actually through going for colorectal cancer screening. And this includes either going for a fecal occult blood test or the fecal immunochemical test, whereby they test or sample your stools to look for occult blood, which is invisible to the naked eye. If it is present, then you should go for something more definitive like a colonoscopy. And sometimes go for CT colonography, which is a non-invasive test of colonic evaluation you have to still take bowel preparation, and they will insufflate some gas through the anus, and they will look for any growths or polyps within the colon. Something that is more invasive but yet therapeutic is going for a colonoscopy. By going for that, you can, one, look for any signs of any features of colorectal cancer, as well as help to do cancer prevention by removing the polyps. So, if you're asymptomatic and average risk, you should go for screening if you're 50 years and above, and this is as per national guidelines. However, if you have the following, such as the family history of colorectal cancer within the first-degree relatives, any history of inflammatory bowel disease, which is a disease whereby you are prone to ulcerative colitis or Crohn's, or hereditary colorectal cancer syndromes, such as familial adenoma polyposis syndrome or hereditary non-polyposis colorectal cancer syndrome, this puts you at higher risk of colorectal cancer. Then you should actually seek earlier medical attention or see your doctor to get advice as to whether you should go for colonoscopy or colorectal cancer screening earlier than what is recommended, which is 50 years and above for asymptomatic individuals. Because at SGH, we have a case for you to be screened, because a colonoscopy at SGH is comfortable, accurate, safe, and easy. So I would now like to pass the time on to Dr. Lin Wenjie, who will talk about colorectal cancer screening, how it may save lives and reduce costs. And Dr. Yvonne will later mention about the process of going for a colonoscopy at SGH. Thank you.
Thank you, Lionel, for the introduction. Hi, I'm Dr. Wenjie. Dr. Chen has already taken you through the signs and symptoms of colorectal cancer. But for these symptoms to develop, as mentioned by him earlier, it is generally at a later stage already. Early detection through screening before the development of symptoms can diagnose cancer in early stages, or even diagnose a pre-cancer stage, resulting in reducing the amount of treatment required and the costs that are incurred. Let me take you through this today. Firstly, let's take a look at the colorectal cancer trends. This has been briefly touched upon earlier. It is the leading cause of mortality in Singapore, number one. Cancer is number one, and with contributing to 30% of all deaths in recent years. It is the most common cancer in Singaporean males and second most common in the Singaporean females, contributing to 17% in males and 13% in females. This is even worse. More worrying for us is that the trend in incidence in colorectal cancer is rising through the years, meaning more and more colorectal cancers are being diagnosed since the 1970s till today. We need to get on top of this, and how do we do that? This calls for colorectal cancer screening. Screening in itself is to look for cancer or pre-cancer lesions before any development of symptoms. Polyps and early colon cancers, as mentioned earlier, have no symptoms or very minimal symptoms, and it's very non-specific. To understand this better, we look at the pathophysiology on how colorectal cancer develops. They develop from polyps through an adenoma to carcinoma sequence, and this takes time, 5 to 10 years. This slow-ish development gives us time for us to intervene, for us to check for it, and for us to have a early intervention to prevent development of late disease and its complications. So why is colorectal cancer screening important? As mentioned, alluded to earlier, screening allows the detection and treatment of precancerous polyps or early stage cancers. Polyps are present in a lot of people, 25% at the age of 50, and this increases with age. And most polyps, like the one you see in the picture on the right, can be removed easily during colonoscopy. And with clean removal and a non-cancerous histological check in the lab, this potentially cures you from a potential cancer. With all this information, however, the screening rates in Singapore is still very, very low at 36.6%. The WHO aim for all countries is looking at 70%, and we're still quite away from this. So who should get colorectal cancer screening? The short answer is everybody. In recent years and back in the past, we know that a few very famous people have succumbed to colorectal cancer, from superheroes like the Black Panther to footballing superheroes like Pele, Ronald Reagan, US President, Audrey Hepburn, and the author of Snoopy. They all had colorectal cancer. Everybody is susceptible, and we should get screening. Why should we get screening? Because screening saves lives. The pie chart on the left shows the stage distribution of colorectal cancer that's diagnosed in Singapore. A quarter still are only getting diagnosed at stage 4, 25%, and 33% at stage 3. This contributes to more than half of the patients having later stage colorectal cancer, which on the graph to the right shows reduced survival. Stage 1 cancer has a 90% chance of living up to 5 years with full cure. But for stage 4 cancers, only 10% survive the same time. So early diagnosis at early stages can save a life. In fact, this is taken from an American website. And they estimate that 60% of colorectal cancer deaths could be prevented through screening. Screening also saves costs. The best case scenario is just a colonoscopy, removal of a polyp, and that can mean cure and prevention of requirement of further interventions and medications. Early stage cancers can be treated with surgery. Stage 2 cancers may require chemotherapy depending on the risk of the colorectal cancer. Stage 3 cancers with lymph node involvements will usually require chemotherapy, and this is recommended. And for rectal cancer, radiotherapy may have to be considered as well. Stage 4 disease is usually considered incurable, and the first line treatment is chemotherapy with considerations of other forms of treatment. With lesser treatment comes with lesser costs. So getting diagnosed early will definitely reduce the cost of treatment. But other than monetary and amount of treatments that a person has to go through, there are many other costs at stake. Cost of time with loved ones, time in good health and not spent in treatment, attending chemotherapy sessions, or being hospitalized from after surgery. Productive time. Cancer treatment is also a cause of disabilities and reduction of productive time in general population. And of course, the side effects of surgery, side effects of chemotherapy can accumulate. So when should we start screening? In a general population with no significant past medical family history of colorectal cancer, 50 years old. In the West, the recommendations in America has reduced to 45 years old, but we have yet to follow suit. This is to help us detect more precancerous lesions, hopefully. And the options are either, as mentioned by Dr. Chen earlier, the fecal immunohistochemical test and colonoscopy. The FIT test detects small amounts of blood in your stools, and this blood is shed by polyps or cancers. Please note that abnormal test does not mean you have cancer. It just means that further tests with a specialist will be required, and this usually entails a colonoscopy. FIT test is done once a year and is part of a Screen for Life package. And the cost, as you can see, is quite minimal, $2 to $5. And if you're a pioneer generation, it's free. Colonoscopy, it can be done at 50 years old for those with average risk. If this is a normal colonoscopy, the recommendation is every 5 to 10 years. If polyps are found, generally speaking, it's 3 to 5 years. If deemed low risk, if high risk polyps are detected, closer surveillance may be required, and this is at the discretion of the specialist. Dr. Yvonne will go further into detail in the colonoscopy later. Next is, am I at increased risk? Should I get screening earlier? Of those with very strong family histories, with first-degree relatives with colorectal cancer or multiple affected relatives across generations, or relatives who diagnosed with colorectal cancer at a very young age, are definitely at increased risk and should seek specialist advice for earlier screening. Personal history of cancer and polyps, any inflammatory bowel disease or inherited cancer syndromes. Patients as such should see a specialist for screening recommendations. That's the end of my talk. I'll hand the time over to Dr. Yvonne Ng. She's a consultant in the Department of Colorectal Surgery, Singapore General Hospital, with a clinical interest in minimally invasive surgery, including robotic surgery for colorectal disease. Dr. Yvonne, please.
Thanks, Wenjie, for the kind introduction. Good morning to everyone joining us here today. It gives me great pleasure to be able to share with you what it's like to undergo a colonoscopy. Let's start off with what a colonoscopy is. A colonoscopy involves real-time direct visualization of the lining of your colon for abnormalities such as polyps or cancer by inserting a colonoscope, which is a flexible tube with a lighted camera at the end, into your anus and slowly advancing it into the rectum and colon. The indications for a colonoscopy can be broadly divided into diagnostic and therapeutic, and often it's a combination of both. My colleagues Dr. Chen and Dr. Lin had earlier covered on early colon cancer detection in asymptomatic patients. A colonoscopy is the gold standard screening tool for colorectal polyps and colon cancer. In picture A, this is a polyp which over time may grow larger and turn more dysplastic, as in B, and eventually may become a cancer, as seen in C. To investigate per-rectal bleeding, abdominal discomfort, and all changes in bowel habits, a colonoscopy is often offered as well to patients who are fit for a scope. The scope may reveal pathologies such as inflammatory bowel disease, diverticular disease, radiation-induced proctitis, and angiodysplasia. Occasionally, we may have the nasty surprise of finding worms during a scope. Two most common therapeutic procedures performed during a scope is a biopsy of the suspicious lesion, such as this, where there's a biopsy of a colon cancer, and polypectomy, as covered by Dr. Lin earlier on. As mentioned, polyps can over time develop into cancer, so it is important to remove them early when it is detected. Often, other uses in the acute setting include foreign body removal, especially in children when they swallow inedible objects such as a battery, which you can see in the X-ray over here. A scope was performed which found the battery as demonstrated in the SICM. A magnetic probe was used to aid in the removal of the battery. Over here, you can see that a safety pin is seen in the SICM as well. It is open and very dangerous. Here we can see that a specialized grasper is used, performed endoscopically to remove the safety pin, and the patient was unharmed. In the adult setting, a colonoscopy can be used to diagnose the cause of acute PR bleeding when patients present to the emergency department, and following that, if amenable for hemostasis. Earlier on, we saw the picture of angiodysplasia. Here we can see that we're using heat energy and clips to stop the bleeding. In patients who may have had previous radiation from prostate cancer or cervical cancer treatment, they may sometimes present with per-rectal bleeding due to the radiation-induced prostatitis. Here, we are using argon plasma coagulation to stop the bleeding. The risk of colonoscopy can be broadly divided into sedation and procedure. Some risks include allergy to the sedative medication if you've never had it before. In more elderly patients, sometimes your blood pressure may go down or your heart rate may increase during the scope. We will usually give IV fluids, and fret not, we also have reversal agents to reverse the effect of the sedation medication. During the procedure, some less common complications that may happen is persistent bleeding, post-polypectomy or biopsy, or in a very rare event, a perforation may occur, which may require an operation. It is necessary to prepare your bowels for colonoscopy to allow us to have excellent visualization of the colonic mucosa in order to increase the yield of the procedure. Following consent for the procedure in the clinic, you will be directed to our listing room where our trained staff will go through with you the preparations required. There are some medications that may need to be suspended, and please bear in mind that this list is non-exhaustive. You can take most prescription medications right up to the day of the colonoscopy. Antidiarrheal iron tablets need to be stopped 7 days prior to the scope. Blood thinners such as aspirin, Plavix, rivaroxaban, etc. may need to be temporarily discontinued prior to the procedure. The length of time is dependent on which drug you are taking, and please ensure that the instructions to stop are given by the doctor who has listed you for the scope, and consult with your prescribing doctor. Please do not stop these medications on your own. Diabetic medications, the doses may need to be adjusted according to the time of your scope, as well as blood pressure medication, which should be continued, but timing may be adjusted as well. You will need to be on a low residual diet 3 days before the scope. Two most common bowel preparation used is the PEG solution and pickle prep. PEG is most commonly offered in SGH as the instructions are easier to follow, and really the prep begins either the night before or before a scope or the morning of the scope if you're scheduled for an afternoon scope. Basically, you need to take if your scope is in the morning, you take a low fiber diet, which will be the last meal before your scope at 6 p.m. Clear fluids only after 6 p.m. Mix 2 packets of PEG powder with 2 liters of plain water. If you don't like water, you can mix it in any clear fluid, but please ensure it is made up to 2 liters. They start drinking from 7 p.m. and complete by 9 p.m. For pickle prep, these are the instructions, and I will just leave it on the screen for you to read at your own leisure. We score the bowel prep from 0 to 3, and we strongly urge to avoid 0 to 1, where there are solid stools occluding the mucosa. This makes the scope very poor yield, and contrary to some patients' belief, we are not able to suction out solid or semi-solid stools. Hence, we will probably stop the scope, and you will have to come back another day, repeat the entire bowel preparation, and go for another scope in another setting. Score 3, where you can see that the bowels are very clean, is ideal and excellent. What happens during the colonoscopy? On the day of the scope, you'll report for the procedure 1 hour before. When it's your turn, you will be brought into the room and we will confirm your identity and position you in lateral decubitus position. We will then give you the IV sedation medication and we will start the scope. The procedure itself takes about 15 to 30 minutes. A colonoscopy is not and should not be painful. Post-colonoscopy, you may experience some mild abdominal discomfort or cramps due to the gas insufflated, but this will usually wear off. You are observed in our recovery area for 1 to 2 hours. 1 hour if there's someone accompanying you home, 2 hours if you're going home on your own. Before you leave, the doctor or nurse will explain the results of the exam and give you a procedure report and, if necessary, instructions for a follow-up appointment. There's strictly no driving or going back to work for at least 12 hours, or rather we just say on the day of itself of the procedure, unless the colonoscopy was done without sedation. What are some alternatives for patients who are not fit to undergo a colonoscopy? A computed tomography colonography is a radiological investigation scan that can be used to produce 2 and 3D images of the colon. Bowel preparation, as seen in this picture, is still necessary, and you will be asked to drink a contrast medium to line the colon before the scan. Before the scan, a soft tube will be inserted into your anus for about 2 to 4 cm, and gas will be insufflated. This scan is very sensitive and can detect lesions up to 0.5 centimeters when the preparation is good. In this picture, you can see that a lesion is detected in the proximal transverse colon. As produced in the 3D imaging of the scan, you can see that there's a pedunculated polyp. On the same day colonoscopy that was performed in this center, it confirms that the polyp was indeed in a proximal transverse colon. The biopsy results showed high-grade dysplasia, so rightfully the polyp was removed. Over here, you can see that the tube is going into the rectum to insufflate the gas, and just adjacent to it, you do find a rectal lesion. It is also confirmed on 3D imaging, and on the same day of the scope, you can see that there's a rectal mass with central depression, and this turned out to be a cancer that was subsequently resected. A more outdated procedure is the double contrast barium enema, which uses X-rays to find abnormal growths in the colon. Barium, a silver metallic compound, is used to outline the colon and rectum on the X-ray. Air is then insufflated through the same tube to further enhance the X-ray. In this case, a classic apple core lesion is present, representing an encircling adenocarcinoma that constricts the lumen. I have now come to the end of my presentation, and I hope we have convinced you today to go for a colonoscopy screening. Thank you.
Yeah, I think we can right now proceed to the Q&A session. So yeah. So I had a right hemicolectomy done in August 2011, and since then had been going for a 3-yearly colonoscopy. I'm now 73 years old. My question is when I can stop getting colonoscopies. I read from Google that the benefits of screening decline at age 75. For most people, there is little evidence to support continuing screening after an age of 85. Yeah, so this is a very interesting question. You are right about it that as we grow older, maybe the screening benefit, we have to weigh actually the risk-benefit ratio if you are an older patient. So the risk of going for something like a colonoscopy, which is invasive, versus trying to pick up cancer. So I would advise you to first consult your doctor who's following up with you for your colorectal cancer. But then again, in Singapore right now, most of us continue to live to quite old age, like older than 80. And at the same time, as we grow older, also we find that there are patients who are 85, 90 who have comes in with symptoms associated with complications associated with colorectal cancer. So my general viewpoint is that if you are healthy and you are fit and with minimal comorbidities, that means like, let's say you don't have any heart disease, any other medical conditions that may put you at risk of an invasive procedure like a colonoscopy, then it's worthwhile to consider still going for colonoscopy. But if you are otherwise, you can either consider non-invasive methods like going for a stool occult blood test, or for example, a CT colonography. Yeah, thank you.
Hey, so the next question is, I'm above 45 years old with family history of cancer. Do I need to get screened for colorectal cancer? So I'm assuming this is a family history of colorectal cancer. And generally speaking, the guidelines for screening are at 50 years old, or if there's a family history, 10 years before the youngest member who had colorectal cancer, whichever comes earlier. So if your family member had colorectal cancer at 50 years old, you should consider getting screened at 40 to 45, generally speaking. If the family member had cancer at 70 years old, then no difference. The screening should still start at 50. Thanks for the question.
Thanks for this question. What is the difference between the non-invasive screening and colonoscopy? So essentially, as mentioned earlier, a non-invasive screening, most commonly often nowadays, is a CT colonography. It is as sensitive as a colonoscopy and can detect lesions up to 0.5 centimeters when the bowel preparation is good. However, the downside is that if a lesion is detected, you will still need to go for a colonoscopy. So in patients who are very fit for a colonoscopy, we usually encourage you to just go for an upfront colonoscopy instead of doing two steps, which is a CT colonal first, then a colonoscopy. In patients who are not fit for a colonoscopy, perhaps because of very old age or you have some chronic comorbidities like a heart condition or neurological condition, then we will usually offer a CT colonography before. And then if indeed a lesion is detected, then no choice, we will need to go for the colonoscopy, bearing in mind that it is a high-risk procedure. Thank you.
If colonoscopy had been done and a small polyp has been detected and removed, will we still require to do another CT scan after 5 to 10 years, or wait for hospital sending reminder of when symptoms detected? Well, this question really depends on what kind of polyp was removed and what's the histology. That means what was the biopsy result. Usually, from the sounds of it, if it's small, it's most likely benign. That means it's not cancerous, and it sounds like a low-risk polyp. Based on guidelines, we can wait up to 3 to 5 years, or sometimes even 5 years, to go for a repeat colonic evaluation, just to look for screening purposes. And of course, if you have symptoms and while waiting for while in this time frame of five years, if you develop any symptoms like colorectal bleeding, change in your bowel habits, it is advisable for you to actually return for a medical evaluation to see whether you need to go for a repeat colonic evaluation, be it through a colonoscopy or a CT colonography. Yeah, thank you.
Can I resume daily activities or work immediately after colonoscopy? Generally not advised on the same day because of the sedation that is given. With sedation, generally the advice is for the next 12 to 24 hours, please do not do strenuous activities, do not drive, and MC will be provided after colonoscopy for 2 days, generally speaking. That being said, some people do choose the colonoscopy done without sedation, and those patients without getting sedation usually are able to get back to normal activities on the same day. Thank you for the question.
Thank you for the question. The question is, I have been experiencing some dark colored stool. Is it something to be worried for? Can I see a doctor in SGH directly without getting polyclinic referral letter? I'll answer this question in two parts. If the dark colored stool is consistent and over a period of weeks or months, and it's not related to any dietary intake, and it's something out of the normal to what you've been having before, then definitely we would encourage you to see a doctor and get yourself a colonoscopy if necessary. Can I see a doctor in SGH directly without getting polyclinic referral letter? Yes, there are two routes which patients fall under, either the subsidized route where you will need to go to a polyclinic to get a referral letter, or as a private patient, you can be referred by a GP, or you can just log on to the SGH website, choose and make an appointment via the SGH appointment system easily. I hope this answers your question. Thank you.
Okay, does taking fiber daily prevent colorectal cancer? Well, actually, I mentioned earlier, it's important to live a healthy lifestyle. But unfortunately, while we can say that you should eat healthily, less red meat, eat more fiber, help promote healthy bowel movements, unfortunately, there are no concrete studies that say that if you take a certain type of fiber or certain dosage of fiber every day, you help to prevent colorectal cancer. There's no concrete studies to date that shows that they can prove this. In fact, a lot of them only just show some associations, but hasn't proved any causative prevention on colorectal cancer. So in the end of the day, the only thing that we are very certain of right now is that going for colonoscopy screen or colorectal cancer screening actually helps to prevent the morbidity and mortality associated with colorectal cancer. Also, if you are able to do a colonoscope, and you show that there's a precancerous or a very small polyp, removing all these polyps, like I mentioned earlier, in the early stages helps to prevent it from transforming to a colorectal cancer. So this is the only way where we know for certain that helps to prevent the disease. Thank you.
Okay, thank you for the question. Is colonoscopy covered by typical employer-funded medical insurance? I think the short answer to this is that it's best to check with your company's HR to see if your particular company's insurance covers colonoscopy. Generally speaking, there is usually some cover, especially with the push for increased screening for colorectal cancer by Ministry of Health. But I think it's best to check before we delve into this, whether employer-funded insurance covers or not. But that being said, colonoscopy, screening colonoscopy at 50 years and above is covered by MediShield and MediSave. So if that can allay some of the worries for finances. Thank you for the question.
Thank you for the question. I'm a 65 years old male and have had 3 colonoscopy screenings with no polyps discovered so far. The last screen was only 2 years ago in 2021. Moving forward, may I replace colonoscopy with annual FIT screen? I felt very giddy and vomited after each colonoscopy. What can be done to reduce the post-screen effect after? If your last scope was in 2021 and you are not at high risk of getting a colorectal cancer, perhaps because of no personal history of colorectal cancer and no family history of colorectal cancer, it is decent if there is no new changes in bowel habits for your next colonoscopy screening to be done in 7 to 10 years. You felt very giddy and vomited after each colonoscopy. What can be done to reduce the post-screen effect? It is important to tell the doctor that is performing the procedure about the side effects that you may have experienced from the IV sedation medications given to you in previous scopes. But what we can do to reduce the post-screen effect is to perhaps give you a lower dosage of the IV sedation medication, give you the reversal agent, or perhaps if you are able to tolerate, to perform the scope without any sedation at all. Thank you.
Doctor, could you please elaborate on treatment for stage 4 cancer? Thanks. Well, this really, actually, how stage 4 colorectal cancer has evolved rapidly over the past 10 to 20 years. Previously, in about 20 years ago, we used to say that in stage 4 cancer is the end, you have to be treated palliatively with just palliative chemotherapy. But right now, for stage 4 colorectal cancer, it really depends on the extent the spread of the disease. Stage 4 means that a colorectal cancer, which is localized to maybe just the colon and the rectum, has already spread to other parts of the body, which means that it has become systemic. This means it can spread to things like the lungs, the liver, and inside the abdominal cavity. Well, while most of the time we may say that stage 4 cancer should be treated with palliative chemotherapy, certain groups of stage 4 cancer can be still considered for cure, meaning that if it's only localized to one organ, for example, to maybe one side of the lung, one nodule in the liver, they can still be amenable to curative treatment, and they do quite well. But then again, before we want to, it is best to always catch cancer early, for example, when it's stage 1 to 2. So therefore, we advocate for because there's additional morbidity and mortality associated with stage 4 cancer, and additional treatment required, such as chemotherapy, more extensive surgery is required. So it's much more better if you can pick it up early, and therefore we advise to go for early colorectal cancer screening. Thank you.
Okay, next question. My dad has a couple of polyps, but doctors said it's inactive and not worry, and don't need any further investigation. Is it okay? Okay, just let me answer this in a couple of parts. So firstly, inactive, I don't quite understand what that truly means, but generally, if we're talking about non-cancerous polyps, it can be divided into a few types. The most common type of polyps is something we call adenomatous polyps. It's what we had described earlier. The polyps that there's a chance in 5 to 10 years can develop into colorectal cancer. Those are called benign polyps, they are also considered precancerous. If those kind of polyps are found and removed during the initial colonoscopy, depending on the number and the risk of the polyps in terms of the risk of development towards cancer, your specialist can advise you for a repeat colonoscopy anywhere between 1, 3, or 5 years, and for close surveillance. Other forms of polyps have no cancer risk, including hyperplastic polyps. If those kind of polyps are detected and removed, the general consensus is to repeat a colonoscopy only 5 to 10 years, just as if it was a normal colonoscopy. I hope that answers the question.
Thank you for your question. I have removed my gallbladder where it caused stomach bloatiness, which is a symptom that doesn't mean more at risk for colon cancer. Abdominal bloating is maybe a symptom of colorectal cancer, usually more in the locally advanced colon cancer, where there may be a certain degree of obstruction. Does it mean that you're more at risk for colon cancer? This is a very non-specific symptom. Usually risk for colon cancer would be a personal history of colorectal cancer, a family history of colorectal cancer, or perhaps more discerning signs such as colorectal bleeding that is acutely developed, and some changes in the stool caliber, such as thinning of the stool. But definitely, if you are worried and this is out of the normal, we encourage you to see a doctor who will refer you to a specialist if required, and we will offer you a scope if necessary. Thank you.
Is it necessary to go for a colonoscopy even though a FIT test is negative for people who are above 70 years of age? Well, a FIT test is done for colorectal cancer screening, and if it's done, it has to be done annually. So, and the thing about FIT is that it only picks up when the polyp or the growth is large enough to cause it to have some occult bleeding in the stools. What this means is that it's only reserved for picking up, it's sensitive for picking up colorectal cancer, but it's not sensitive to pick up precancerous polyps. That means polyps that have yet to turn cancerous. So even if your FIT is negative, but if you want to be very certain that you want to prevent or reduce your colorectal cancer risk, is to still go for a colonoscope. Because if you can see a polyp there, which would not yield any form of blood or occult blood in a FIT test, you can remove it, and this increases your chance of having lower cancer risk. Thank you.
Hi, so next question, do I need a referral from polyclinic for subsidized colonoscopy? I'm 45 years old with multiple relatives with colorectal cancer. So I'll answer in two parts. So firstly, do you need a referral from polyclinic? You can get a referral from either polyclinic or from a CHAS subsidized GP clinic to come to see us at SGH. With such a history, the appointment that will be given to you will be and to be a subsidized patient, yes, a referral letter will be required. 45 years old with multiple relatives, as mentioned in my talk, those with multiple first-degree relatives or multiple relatives across multiple generations or young relatives with colorectal cancer should consider earlier screening, as this could potentially put you at higher risk. And consult with your specialist will be advised for us to elucidate this information to tell you your exact risk and when you should start colorectal cancer screening with colonoscopy.
Thank you, Claire. Thank you for your question. This question is on a family history of colorectal cancer. Does it matter at what age our parents have colon cancer? Example, parents were diagnosed that they have colon cancer only at age 75 to 80 years old. Does it mean I have an increased risk of colon cancer? Usually when we talk about family history of colorectal cancer, the higher risk one would be when the patient's relative, first degree relative, was diagnosed at an age younger than 50 years old. So definitely what we encourage is that if you have a family history, for example, a parent that was diagnosed at 45 years old, then definitely your scope should be done at 40 years old. If your parent was diagnosed at 80 years old, then we would encourage you to have your first scope at 40 years old instead of the routine 50 years old.
Is it advisable for a person above 79 years of age with history of UC but now fully recovered to do a colonoscopy because of discomfort and risk? Firstly, we need to know what's your history of UC. I think this question you really have to actually seek your own primary gastroenterologist or your colorectal surgeon who has been seeing you for your UC, because for UC, yes, you are at increased risk of colorectal cancer, but I'm not sure about your whether you had a previous surgery to remove your colon, because if you had removed your entire colon for UC, you are actually essentially of lower risk of having cancer. But so I actually advise you, if you have the above symptoms, to actually seek formal medical attention. Yeah. Okay. Thank you.
Oh, the question on cost of colonoscopy and is MediSave usable? Okay, so for colonoscopy, let me answer the first part first. The cost of colonoscopy in SGH as a subsidized B2 patient is about $1,000. And this is MediSave claimable if you're 50 years and above. Under 50 years and above, and this can MediShield can also be used for subsidize the cost of colonoscopy if you fit into that category. Of course, if during the colonoscopy polyps are detected and additional tools are employed to remove the polyps, clips, for example, and snare wires, for example, the cost may increase slightly. Thank you.
Thank you for your question. Does diverticulitis increase the risk of colon cancer and therefore require more regular screening? No, diverticulitis does not increase the risk of colon cancer and therefore does not require more regular screening. However, colon cancer, diverticulitis may be a result of an obstructing lesion such as a colon cancer. So what we usually do in patients who do present acutely with diverticulitis, they are treated conservatively if they are non-septic with antibiotics and sent home. We will review in the outpatient setting and offer a scope to these patients after 6 weeks after the acute episode to ensure that there is no underlying colorectal cancer that is causing the diverticulitis. Thank you.
If a person had went through all the screening and cannot find anything wrong, but the CA19-9 and the CA, what could be wrong? and what should the patient do? Wow. Firstly, when we see, that's the thing about tumor markers. Firstly, I want to clarify that tumor markers are not diagnostic, and it's not a screening modality for cancer, any types of cancer. But I understand that a lot of our health screening packages, outpatient settings may offer them. And unfortunately, we will see these patients with raised tumor markers. What we usually would do is we'll do a full colonoscope, a stomach scope also, because the CA, when it's raised, is quite non-specific. It can be associated with other types of cancer, not just colorectal cancer. It can be associated with gastric cancer, thyroid cancer, and CA19 may be associated also with colorectal cancer as well as pancreatic cancer. So it's all very non-specific. So even after all the scopes are done, what we usually would do is we have to screen for other cancers. So we'll do an ultrasound thyroid, we may do a CT scan of the entire body, and all this, while it drives up costs, is to actually ensure that we do not miss anything out. But if all have turned negative, then we have to exclude, then the raised tumor markers may be due to other causes. And for CA that is raised, it can be associated with other things like underlying medical condition, like if you have chronic kidney disease, any chronic liver problems can also cause raised tumor markers. Or if you are smoking, if you have been smoking a lot, this is also associated with a raised tumor marker. So ultimately, I think once, if all the tests have been done for a raised tumor marker has been done and it has shown that there's nothing, then the physician and the surgeon may have to attribute it to other causes that are not associated with cancer, and reassurance is given to the patient. Regards to the person asking this, if you have any doubts, please return back to your primary physician who has been seeing you and treating you to answer and clarify all other questions. Thank you.
Okay, next question. What is the difference between doing a colonoscopy in private or in SGH? I think Dr. Lionel, through his presentation, has already made a case for you to do your colonoscopy in SGH. When we do in SGH, we can assure that it will be comfortable, it will be accurate and safe. And of course, if you come to the referrals to our department for colonoscopy to be done, it will be done by one of the specialists, accredited specialists in the colorectal surgery department. And our department does the highest number of colonoscopies across the country. So generally speaking, it will be accurate, it's safe, and it's comfortable. If you were to do in private, of course, you have to do your own background research where we can't promise or assure who will be doing the scope for you. I think that's about it for me. Prof. Emil, anything else to add?
No, I think you've covered it well.
Thank you for your question. If a CT scan showed something, is there a need to investigate with a traditional colonoscopy procedure? Definitely, if a CT scan, we're talking about CT colonography, or even a CT abdomen pelvis picks up something that suggests that there is a lesion in the colon, then we will offer you a colonoscopy procedure to ensure that we have a real-time visualization of the lesion and perform a biopsy or polypectomy or whatever else that requires to be done for it.
Okay, I'm 53 male and I sometimes experience pain in my anus in the night, causing me to go to the toilet to pass motion. Seems like postalgia fugax. Is this related to colorectal cancer? Well, yes, you're right. Postalgia fugax is what we call one of the elements under a functional bowel disease. But before we can label it as such, it's important to exclude symptoms, whether it's colorectal cancer. So if you had never had a colonoscopy done before, it is prudent, and you haven't seen anyone in a medical field or a doctor for your own symptoms, I do encourage whoever is asking this question to seek early medical attention, and to also undergo maybe a colonoscopy first to exclude colorectal cancer. And after which, then we can, if it's normal, then we can help to treat your other functional symptom. Thank you.
Next question, is a person aware of the operation? Can a patient request for GA for colonoscopy? Okay, I'll answer this in two parts. So firstly, Awareness during colonoscopy, it may be possible for some patients. It is, after all, called conscious sedation, where the amount of medications given does not amount to a general anesthetic. Some patients are completely unaware, of course, but the importance of conscious sedation is that the person undergoing the sedation as well as colonoscopy will continue to breathe by himself or herself, and without any anesthetist putting in a breathing tube. Some patients who have the amount of tolerance is slightly different, much like tolerance towards alcohol. Some people would be aware, may be aware during the colonoscopy, but generally speaking, it's still okay and quite comfortable and tolerable. Some patients can also do this without sedation, so that adds up. Can we request for a GA for colonoscopy? The short answer is probably no. That being said, it's because the risk of general anesthetic usually is, there is some risk related to general anesthetic, and colonoscopy is a short and safe procedure, whereas general anesthetic is not required in most cases. Of course, if you have other medical conditions that would preclude the use of conscious sedation and would require general anesthetic and anesthetist support during colonoscopy, that can be discussed during the consult. But again, most of the time, GA is not required for colonoscopy.
Yeah, if I may add to that, Jie,
Okay.
the GA is not normally offered in most hospitals as a routine, but if it's really necessary, there are certain reasons, and there are good clinical reasons to do so. This can be done. So we do it on a case-by-case basis. However, I would like to stress that most of the scopes and the sedation that we give, you won't feel anything. It's very comfortable. Most of the people that give us the feedback tell us it's like being to a spa, and then when you wake up, it's all done. So I think maybe don't worry so much. You know, it's a very, very good sedation. Is very, very good nowadays. And you know that when you come to SGH, you have quality endoscopists. So you'll get a very good experience, be very comfortable, and be very, very smooth sailing. Thanks.
Thank you for your question. I may have answered this in the text, but anyway, on preparation for a colonoscopy, do patients need to suspend anti-cholesterol medications like statins? No, you do not need to suspend statins for the scope. Thank you.
My hubby is on blood thinner medications. Can he go for colonoscopy? Well, it really depends on what type of blood thinner medications is he on. Is it an antiplatelet like aspirin, or is it something as strong as Plavix? As well as, is he on something what we call anticoagulations, like things like warfarin and rivaroxaban? These are all very different kinds of blood thinner medications. So you can still go for a colonoscope depending on a certain type of blood thinners you are on, as well as a discussion between the endoscopist and the patient and the family as to whether you are willing to undergo an invasive procedure while holding off your blood thinners for the certain medical condition you are on. For example, if you are requiring your blood thinners for something that there's a clots in your heart, all this, we have to weigh the risk of having any blood clots that are forming that may form when we hold off the blood thinners for a prolonged period of time for the purposes of doing a colonoscope safely. So I think with regards to this question, I suggest you have to really consult your physician or your endoscopist that you're seeing and to have a discussion on the risk-benefit ratio between holding off the blood thinners and going for an endoscopy. So please seek appropriate medical advice. Thank you.
Okay, this question is, I had a colonoscopy done 1.5 years ago and a polyp removed. Did a recent FIT and one of the stool had trace blood. What should you do? Okay, so generally speaking, again, when we have a polyp removed, 1.5 years, and this assuming it's a low risk polyp, the recommendation is a repeat colonoscopy 3 to 5 years. Since that you've done a FIT with a trace of blood test, the referral to a colorectal surgeon or a specialist would have been triggered by Health Promotion Board. And you should go speak to the colorectal specialist, and we would still recommend a repeat colonoscopy, given that there's a new FIT positive, just to be thorough, to be certain that there's nothing that we missed nothing that will be missed, and it's for your safety as well.
Great. Thank you very much to all our speakers, Dr. Lin, Dr. Chen, and Dr. Ng. We've had a wonderful set of talks today, and I hope all your questions have been answered. Okay, I think that ends our congress today. Thank you very much for being here. Thank you to all our speakers, and don't forget that screening saves lives, and it's important to come to us as early as possible. Thank you very much, and have a very good afternoon, great weekend. Bye-bye.